All right. So without further ado, let's start, Claude. It's my honor and the pleasure to co-direct this course with Dr. Bob Marks from San Diego. We have great speakers, great lineup of speakers here. We're starting by Dr. Sirlin, who is going to talk about what's LI-RADS history and evolution. That's today. Tomorrow, we're having Dr. Victoria Cherniak, and she's going to talk about overview of CT and MRI algorithms and major features. Wednesday, Catherine Fowler from UCSD is going to talk about malignant lesions that are not definitely HCC, LRM. On Thursday, we have Alessandro Furlan from Pittsburgh, and he's going to talk about LI-RAD, tumor in vein, tumor and plant thrombus. Friday, April 24th, we have Jimmy Lee from Kentucky, and he's going to talk about ancillary features. Then Monday, I'm going to speak about pitfalls in imaging of cirrhosis and user errors in applying LI-RADS. Next Tuesday, we're having Richard Du. He's going to talk about, and he's from Memorial Sloan Kettering. He's going to talk about evolution of local-regional treatment response. Michelle Lala from University of Michigan, she's going to talk about evaluation of systemic and radiation therapy, and this is going to be Wednesday, April 29th. Thursday, Bob Marks from San Diego is going to talk about present and future of LI-RADS. Friday, May 1st, we have Anya Keeler going to talk about LI-RADS case-based review. Amit Singhal on Monday, May 4th is going to talk about is there a clinical need for LI-RADS. Tuesday, May 5th, we have Don Mitchell from Thomas Jefferson and is going to talk about management recommendations of LI-RADS categories. Avinash from MGH on Wednesday, May 6th is going to talk about LI-RADS technical recommendations. Thursday, May 7th, David Fitzer is going to talk about contrast enhanced ultrasound of the liver. May 8th, Aya Kamaya is going to talk about ultrasound screening of hepatocellular carcinoma. May 11th, we are having Dr. Mustafa Bashir is going to talk about imaging of liver iron deposition and the steatosis. Without further ado, it's my great pleasure to start the first day of our series with Dr. Claude Sirlin. Claude Sirlin is a great guy. He is really great person, great leader. He's getting a lot of people together, a lot of experts together for a mission of standardizing the diagnosis of focal lesions or focal observations in cirrhosis. And he has been developing this with a strong vision and a lot of efforts. He's been leading it. The credit goes to him, not only for developing LI-RADS, but also for developing leaders all over the country and all over the world. He has been leading LI-RADS since 2006, and I'm going to give the presentation to Dr. Sirlin.
Well, Khaled, I just want to say that it's really my honor and my pleasure. So thank you for inviting me to this, and thank you whoever is out there listening to us virtually. Thank you so much for joining. Oh, Khaled, thank you for organizing this. It's amazing that so many people have registered in such a short amount of time. I think you sent this notification just last week, right? On Thursday or something like that?
Actually, yes. It's on Friday, so it's just a 3 days notice, and we have an overwhelming registration. It's just because people like you, Claude.
Oh, no. I think it's because people like you. But anyway, I'm very impressed, Khaled, with your leadership and your ability to organize things so fast. It's great. It's my honor to participate in this stellar lineup you've assembled here. I'm going to be giving an overview of the liver imaging reporting and data system, talking a little bit about what it is in very sort of broad terms. briefly review the history and evolution, and then give a little bit of a glimpse into the future. I'm not going to get into a lot of detail about LI-RADS because there's going to be more details and more information forthcoming from this amazing lineup of speakers that Khaled and Bob Marks, the course directors, have assembled. Okay, all right. Well, once again, thank you all for participating in this online course. My relevant financial disclosures are shown on this slide over here. And I was asked to speak about LI-RADS and to explain what it is. I was asked to explain a little bit about the history and evolution, and so I thought it would also make sense to talk just a little bit about the future of LI-RADS. So this is my outline, and I'll start with what is LI-RADS. So LI-RADS is a system for standardized imaging of liver cancer. In particular, LI-RADS standardizes the terminology, the language that we use for imaging liver cancer. It standardizes the imaging technique. Shown here is an MRI with gadolinium disodium. It standardizes the interpretation, and shown here is an example of how observations are interpreted on CT and MRI. It standardizes the reporting that are issued by radiologists, and shown here is a standardized template for CT and MRI reporting. And it also offers hope for standardizing data collection. Now, I'd like to emphasize that LI-RADS focuses on imaging, and so everything that is illustrated in this slide with respect to standardization has to do with imaging and not necessarily other things that are relevant, such as clinical care or surgery or pathology. Now, LI-RADS has 4 interpretation algorithms: ultrasound for surveillance of hepatocellular carcinoma, contrast-enhanced ultrasound for diagnosis of hepatocellular carcinoma. It has an interpretation algorithm for CT and MRI diagnosis, and this applies for diagnosis and staging of this malignancy. And LI-RADS also has a treatment response algorithm for CT and MRI, which currently applies for the assessment of response to local regional therapy. So 4 separate interpretation algorithms. Now, just to sort of repeat what I said on the prior slide, but maybe put it in a slightly different way, I'd like to just emphasize that LI-RADS currently addresses 5 imaging methods, and the imaging methods are shown here: ultrasound, contrast-enhanced ultrasound, CT, MRI with extracellular agents, and MRI with hepatobiliary agents such as gadolinium. And the 4 clinical contexts are shown here. So we can see that currently LI-RADS applies ultrasound for screening and surveillance. These other methods are all used for diagnosis, and CT and MRI are also used for staging and for assessing treatment response. We're developing a protocol or an algorithm to use contrast-enhanced ultrasound for assessing treatment response, but that is not yet available. Now, LI-RADS provides a standardized lexicon for liver imaging. Lexicon is defined as the vocabulary of a branch of knowledge. In this case, the branch of knowledge would be the branch of knowledge related to liver imaging. And our hope is that by providing a standardized lexicon for liver imaging, the standardized lexicon could be used universally around the world, so that radiologists, clinicians, surgeons, patients, etc., everywhere around the world would be using the same terminology when it comes to liver imaging. And toward the end of this lecture, I'll circle back to this idea of a universal lexicon for liver imaging and how that might be useful. Now, in order to facilitate the use of LI-RADS throughout the world, LI-RADS has been now translated into 11 different languages, and this effort was led by Ann Tang, who is chair of the LI-RADS International Working Group, as well as the hard work of several individuals, some of whom might even be attending today's course, who actually did the hard work of translating LI-RADS into these various languages. Now, LI-RADS has recently expanded into pediatric imaging. There's a pediatric imaging working group led by Alex Tobin, and that group has recently come up with consensus recommendations for imaging of pediatric neoplasms, in particular hepatoblastoma, HCC, as well as other tumors. And a paper has been submitted to Radiology to describe those consensus recommendations for pediatric tumor imaging. LI-RADS is comprehensive. It addresses the entire spectrum of liver lesions and pseudolesions. The spectrum includes lesions such as shown here, cirrhosis-associated hepatocellular nodules, which can span from regenerative nodule all the way to hepatocellular carcinoma, non-hepatocellular carcinoma malignancies such as cholangiocarcinoma, additional lesions, including benign lesions that might be seen in the liver, lesions that are not actual masses, such as focal or regional fat deposition or sparing, some masses that are just basically giant confluent areas of fibrosis, as well as treated lesions. And LI-RADS also addresses pseudo-lesions, including arterial portal shunts and other vascular pseudo-lesions, as well as a few other things. So LI-RADS is comprehensive. It addresses the entire spectrum of lesions and pseudo-lesions encountered in the liver. Now, LI-RADS was initially developed for application in clinical care, but LI-RADS can be used, and we encourage the use of LI-RADS for research as well as for education. LI-RADS is supported by the American College of Radiology. This is the organization that in the United States promulgates the standardization of imaging quality and safety metrics. Very importantly, in 2018, so 2 years ago, LI-RADS became integrated into the AASLD clinical practice guidance. The AASLD is the American Association for the Study of Liver Disease. It's the leading hepatology organization in the United States, and arguably it's one of the most important hepatology organizations in the world. So the integration of LI-RADS into the AASLD clinical practice guidance was really a major achievement for LI-RADS, and shows that it is now being accepted more and more by the hepatology community. Very important to understand something. LI-RADS is dynamic. LI-RADS will be expanded and refined as knowledge accrues and in response to user feedback, with major updates expected every 3 to 4 years, and the next update is currently planned for 2021 or possibly 2022. Now, I want to emphasize that LI-RADS will respond to user feedback. So as anyone who is listening to this lecture, either live or later listening to the link, please let us know whether you have suggestions for how to make LI-RADS better. We will listen to your feedback. You can contact us at this link over here, rads@acr.org, and send your feedback. What do you like? What do you not like? What could be better? And we will take into account your feedback, and we may make changes in response. So that's a little bit of an overview of LI-RADS, but now I want to dig just a little bit deeper by briefly reviewing the CT and MRI diagnostic algorithm. The first thing to know here is that the CT and MRI diagnostic algorithm applies to patients with cirrhosis and other patients at risk for HCC. So very important to understand that LI-RADS applies only to patients at high risk of HCC. And currently in the year 2020, we believe that that means patients with cirrhosis of most causes. So cirrhosis due to hepatitis B, cirrhosis due to hepatitis C, cirrhosis due to alcohol, cirrhosis due to obesity and fatty liver disease. So cirrhosis of most causes. In addition, it can apply to patients with chronic hepatitis B viral infection, even if they don't have cirrhosis. And finally, it can apply to patients who, for whatever reason, even though they have no apparent risk factors, happen to have now or in the past hepatocellular carcinoma. This list includes adults that either are liver transplant candidates, as well as adults who have had liver transplant in the past. So this is who LI-RADS applies to. LI-RADS does not apply to children, namely those that are less than 18 years old. And it doesn't apply to adults with vascular disorders of the liver, such as Budd-Chiari syndrome. Does not apply to adults with cirrhosis due to congenital hepatic fibrosis, and does not apply to adults with pre-cirrhotic liver disease, unless, of course, that disease is chronic hepatitis B. So just to be clear on this, if someone has cirrhosis due to hepatitis C, LI-RADS applies. If someone has cirrhosis due to Budd-Chiari syndrome, LI-RADS does not apply. Do not use the LI-RADS algorithm in that context. Now, why is this? The reason that LI-RADS applies only in patients at high risk for HCC is that if the pre-test probability, if the risk of HCC is high due to underlying liver disease, then a lesion that meets stringent imaging criteria for HCC is in fact HCC. It can be diagnosed as HCC with certainty. So there's an expression in English that says that if it walks like a duck and it talks like a duck, then it is a duck. So similarly, if there's a lesion in the cirrhotic liver that looks like an HCC, then we can make the diagnosis of HCC. But we can't make that diagnosis if the pretest probability of HCC is low, so we cannot use LI-RADS if the pretest, if someone doesn't have one of the risk factors we talked about on the prior slide. Now, once we know that someone has cirrhosis, LI-RADS then begins with detecting an observation. So here we have an image of the liver. The liver is cirrhotic, and notice there are innumerable tiny little nodules in this liver surrounded by fibrotic bands. So this is a cirrhotic liver. And what we need to ask ourselves is, are there any parts of this liver that look different? Are there any distinctive areas? And in this case, we look carefully and we say, yes, there is a nodule in this liver that looks different than the background. And that nodule that looks different is what we call an observation. So if an observation has been untreated, it has not been treated by an ablation, it has not been treated by embolization or any other treatment, then we assign a diagnostic category, and the diagnostic categories are shown here, and I'll talk a little bit about those diagnostic categories in a moment. So these diagnostic categories are designed to reflect the radiologist's thought process. They are designed to communicate the radiologist's degree of certainty, and they are designed to be comprehensive and to address the entire spectrum of lesions and pseudolesions in the liver, as we talked about a few slides ago. Now, ideally, a radiologist would be able to look at every single lesion in the liver and determine with 100% certainty that the lesion is definitely benign, and we'd call that a LI-RADS 1, or definitely an HCC, and we call that a LI-RADS 5. But in the year 2020, we do not have that ability. There's not a single radiologist on the planet Earth that can look at every lesion in the cirrhotic liver and say with 100% certainty it's benign or HCC. They might be able to say that for some lesions, but not for every single lesion, because sometimes there's some degree of uncertainty. And so if the radiologist thinks that it's probably benign, but it's not 100% certain, we call that a LI-RADS 2, or probably benign. If the radiologist thinks it's an HCC, but it's not 100% sure, we call that a LI-RADS 4, or probably HCC. And if the radiologist is unsure at all whether it's more likely benign or malignant, then we call it a LI-RADS 3, intermediate probability of malignancy. But there's a missing category here, and the missing category is that sometimes the radiologist is fairly sure that it's malignant, but the radiologist is not positive that it's an HCC and thinks that it may be a cancer other than hepatocellular carcinoma, and that's the category LI-RADS M. Now, sometimes there's an observation that's actually invading a vein, macrovascular invasion, and we call that tumor in vein, and this is an LRTIV for tumor in vein. And every once in a while, but very rarely, because images are degraded or images are missing, we simply cannot categorize an observation into one of these categories, and that's considered LRNC for not categorizable. Now, what are the actual percentages of HCC and malignancy associated with these LI-RADS categories? Well, some of the evidence is now emerging. We now know that based on the published literature, 0% of observations categorized by radiologists as LI-RADS 1 are HCC and 0% are malignant. For LI-RADS 2, according to the published literature, 13% are HCC and 14% are malignant. For LI-RADS 3, it's 38% and 40%. For LI-RADS 4, it's 74% and 80%. For LI-RADS 5, 94% are HCC, 97% are malignant. Remember that LI-RADS 5 is defined as definitely HCC. So we can see from the published literature that LI-RADS 5 does not work quite as well as we had hoped, but it's working quite well with 94% probability of HCC and 97% probability of malignancy. LI-RADS M, which is the category where the radiologist thinks it's malignant but is not sure that it's HCC, it turns out that 93% of these are malignant and 36% of these are HCC. Now, you will learn in future lectures given by some of the other speakers how LI-RADS assigns these categories. So I'm not going to get into that today. But for now, what I want everyone to realize is that each category conveys a different probability of HCC and a different probability of malignancy. And because each category is unique, these categories can help to tailor patient management. Now, you'll learn more about patient management in a subsequent lecture, and so I'm not going to get into it into detail, other than to notice that every single LI-RADS category is associated with a slightly different management recommendation. And I'm not going to get into all these details, but I do want to just emphasize one thing for today. So notice that for LI-RADS 5, no biopsy is required because HCC is confirmed. For LI-RADS M, we're quite sure that it's a malignancy, and in fact 93% of LI-RADS M's are malignant, but only 36% are HCC, so we don't know what kind of cancer it is. And in order to appropriately manage the patient and know what kind of treatment they need, we may need to do a biopsy. So LI-RADS M frequently gets a biopsy, but LI-RADS 5 typically does not need one. Okay, so I've spent the last several minutes giving a little overview of what is LI-RADS. What I'd like to do now is spend a little bit of time talking about the history and evolution of LI-RADS. Now, LI-RADS started in 2006, 14 years ago, with a complaint. And it started because our hepatologists were not happy with our radiology reports at UC San Diego. Alex Kuo, who was then the chief of hepatology at UC San Diego, asked me to come into his office one day, and he said that he has a problem. Yuko Kono, one of his colleagues in hepatology, agreed, and she said to me, we cannot interpret your radiology reports. Marcus Hart, who was then the chief of liver surgery, said, we don't care if you're right or wrong. And his surgical colleague, AJ Khanna, said, we just want you to be consistent and clear. So they were complaining that our radiology reports were confusing and uninterpretable. And they were right. Our reports, in fact, were terrible. These were the kinds of terms that we were using in our reports: indeterminate, equivocal, suspicious, HCC should be considered, et cetera, et cetera. And as you look at these various different reports that we were issuing, I think you can appreciate that these reports are murky, they're unclear, they're not granular, they don't communicate clearly what we thought. And of course, nothing is worse than this one, recommend clinical correlation. How can a surgeon or a clinician look at a 9mm nodule and apply clinical correlation to figure out what that nodule is? What is the clinician supposed to do? Palpate this 9mm nodule through the skin? So recommend clinical correlation is a garbage thing to say, and it doesn't clearly communicate to anyone what you think is going on. So our reports were ambiguous, and our reports did not provide actionable information. So we realized we needed to do something better, but we also realized we didn't need to reinvent the wheel, because there was already a system for breast imaging called LI-RADS, and we realized that we could adopt or adapt some of the concepts of LI-RADS and apply it to the liver. And we came up with an embryonic version of LI-RADS back in 2006. So here is the development and refinement of LI-RADS since 2006 to the present. And I'd like to just go over a few of the key events. So in 2008, the American College of Radiology convened a committee to develop LI-RADS at a national level. In 2011, after 3 years of effort, version 1 of LI-RADS was released, which at that time applied only to CT and MRI with extracellular agents. In 2013, we developed an algorithm and an atlas, but it still applied only to CT and MRI with extracellular agents. In 2014, we added hepatobiliary agents to LI-RADS, and in 2017, we added ultrasound, contrast-enhanced ultrasound, and we also developed a treatment response algorithm. In 2018, we made some modifications that allowed us to achieve unification with AASLD, as I mentioned earlier. We also simplified some of our definitions and criteria, and we created an online manual, which is a comprehensive review or a comprehensive reference for imaging of the cirrhotic liver. In 2020, this year, we released a lexicon for liver imaging, and we are in the process of releasing consensus recommendations for pediatric imaging of pediatric liver tumors. Now, what I'd like to also point out is that when we first started in 2006, there were 4 members of LI-RADS from 2 institutions in the United States, and over the last 14 years, LI-RADS has expanded to having over 250 contributors from over 100 institutions from over 30 countries. And if anyone on this webinar is interested in contributing to LI-RADS, please reach out to either me or to my co-chair, Professor Cherniak, and we'll see if we can potentially find a way for you to get involved. Now, LI-RADS has a steering committee, and the steering committee oversees 15 different working groups. Each working group focuses on different things. So, for example, this working group focuses on the lexicon and the manual. This working group focuses on benign liver lesions, and this one focuses on contrast-enhanced ultrasound, et cetera, et cetera. Now, how was LI-RADS developed? LI-RADS was developed based on a blend of evidence, expert opinion, user feedback, and a desire to be congruent with the systems that were in place, at least by other societies, mainly in the United States, because LI-RADS started in the United States. It was a blend of all of these things. Notice that LI-RADS was not developed purely based on evidence. It was, in fact, based on evidence and a blend of other things. Now, some of you might be wondering, why was LI-RADS not created based on evidence alone? Wouldn't it be better to create it based on scientific evidence and not on those other things? Well, the problem was it was not possible to create LI-RADS based on evidence alone, because sometimes the evidence did not exist, and sometimes the evidence did exist, but the evidence was not published using a standardized lexicon, and it was not possible to extract from the published literature the information with the detail we needed to create LI-RADS. So it was just not possible to create LI-RADS based on evidence alone. Sometimes you just have to create something, and then you can ask questions later. And that's what we did with LI-RADS. We decided to create it, and then over time, the evidence is starting to come in that is in part validating LI-RADS, but also in part telling us where we need to get better. And future lectures will be talking about this. So I've talked a little bit about the LI-RADS history and evolution. Let's just now look a little bit into the future. So what does the future of LI-RADS look like? Well, I mentioned that LI-RADS is dynamic, and LI-RADS will be expanded and refined, as I mentioned earlier, as knowledge accrues and in response to user feedback, with the next major update expected in 2021 or 2022. LI-RADS will expand in scope. We're trying to standardize the terminology between radiology and pathology. We're expanding into benign liver lesions, not just liver cancer. We've already talked a little bit about the expansion into pediatrics, and we have a group that's looking at future research directions to guide the future improvement of LI-RADS. We are also hoping that LI-RADS will be integrated into commercial reporting systems, and this is an important effort that's being led by some of the individuals shown on this slide. And our hope is that by integrating LI-RADS into commercial reporting systems, we will someday be able to describe into our dictation system the key terms, the standard terms that we need. But notice that we won't have to say it in an organized fashion. We can dictate potentially in a disorganized fashion as long as we are describing the key terms, and the computer will be able to organize our thoughts and apply the LI-RADS algorithm and provide a very organized report that's more organized, in fact, than our thought process. So I think in the future, radiologists won't need to memorize LI-RADS. They simply will need to describe what they see, and the computer will be able to generate a LI-RADS report from those descriptions. And once that happens, this will allow the development of LI-RADS registries that will provide the evidence that we need to fully validate LI-RADS and inform its future improvement. But now I'd like to pause for a second, because the reason we're all here today on this webinar is because of this virus here, the coronavirus, which is affecting the entire planet Earth. This was yesterday at 8:30 p.m. Eastern Time, and this is a map of the effect of coronavirus around the world. And what you can see is that with the exception of 3 countries, every single country in the world is affected by the coronavirus. And the only 3 countries that are not affected simply probably haven't reported those cases. They probably actually are affected. So the coronavirus knows no boundaries. Now, one of the problems that we've had in the United States, at any rate, and possibly in other countries as well, is that our supply chain is dependent on other countries, and because our supply chain is dependent on other countries, we haven't been able to get all of the equipment we need, including basic equipment such as masks and other protective equipment. And this has led some people in the United States to wonder whether we need to become less dependent on the rest of the world. And so experts are wondering whether we need to rethink how much any country wants to be reliant on any other country. But what I'd like to point out is this may be true for the physical supply chain. This may be true for things like masks and ventilators and protective equipment, but this is not true for communication and information. It's just the opposite. For communication and information, countries must communicate even more with each other than they ever have before. We need more communication between countries and across the planet Earth. We need more information sharing, not less. Because liver cancer knows no boundaries. Now, earlier I showed you a map of the coronavirus. Here is a map from 2019, 1 year ago, showing the mortality around the world due to liver cancer. And notice that every single country on the planet Earth, with the exception of just a few countries where we don't have the information, are affected by liver cancer. Every country is affected by liver cancer, and we need to learn from each other. And notice that when we learn from each other, the communication has to go in both directions. So the teacher is the student, and the student is the teacher, and we have to teach one another both within societies as well as internationally. And this is what I mentioned earlier, that I think it's possible that LI-RADS might be able to help with communication and information sharing. And so let me share with you a vision for what I think might happen in the future. Imagine that everyone around the world was using LI-RADS, either the LI-RADS system itself or at least the LI-RADS lexicon, the LI-RADS terminology. If we were all using the LI-RADS terminology in our radiology reports, then we could create an international database. And imagine the following situation. I, as a radiologist, have a patient, and I see a small little observation in the liver. I plug in some data. I plug in some clinical data. I plug in the treatment history. I then plug in some imaging data. And whether I'm using LI-RADS or not, I'm using the LI-RADS lexicon. So I measure the observation, and I say that this observation has non-rim AFI. It does not have washout. It does have an enhancing capsule, et cetera, et cetera, et cetera. Maybe I have information on the background liver, or maybe I don't. And then, based on a registry that we have across the world, the registry will tell me that based on 110 observations around the world that look like this observation, the probability of HCC is 91%, and the probability of malignancy is 94%. Now, initially in this international registry, we only have 110 matched observations, and so there's a confidence interval around these estimates. But a couple years later, we may have, instead of 100 matched observations, we might have 2,000 matched observations. And now suddenly I have a much more focused and narrowly defined probability of HCC and malignancy. And if we were to develop these international databases, all of us could benefit from this international collaboration, because no matter where this patient is, you'd be able to access this international database, and the computer would be able to tell you that based on how many observations are similar to the one you're seeing, what the probability is of HCC and malignancy. Now, maybe this sounds a little bit like pie in the sky, maybe this sounds unrealistic, but I'm telling you that we have the technological components now to do this. We just need to assemble the machinery. But every technological component that is needed to create that system currently exists. We now just need to bring them together. Okay, well, I've talked about LI-RADS in broad terms today. If you want to learn more about LI-RADS, I recommend that you download the LI-RADS materials, which are available through the ACR website. Whatever search engine you use, simply type in LI-RADS and it will take you to the appropriate website, and you'll be able to find the ultrasound core, the CT and MRI core, the contrast enhanced ultrasound core, the CT and MRI manual, the lexicon, and you can download these and they are completely free. These are accessible to you, and I urge you to go to the ACR website and to download some of these materials. In addition, please stay tuned, because in the 2 weeks that follow, we will have excellent lectures by all of these speakers that will get into more detail about how to apply LI-RADS. And so with that, I'd like to thank you very much for your attention.